Is the
Word go.
clock on the upper left is counting?
Yes, sir.
Okay.
So fun. Is everybody ready? You ready? You got everything? Okay.
It's your show.
Hi guys, my name is Laura Waller, and I'm presenting on Jones fracture treatment and rehabilitation. So a quick introduction of a Jones fracture. They are fractures of the base of the fifth metatarsal. They account for 45 to 70% of all foot fractures, which is a pretty wide range. And there was another study that showed that within the foot itself, they account for about 2% of foot fractures. Or not in the foot, but in the body total. They are 2% total fractures, which isn't very many. So these are difficult to treat because of the lack of blood flow to the area. There's also a high non-union rate of the bone itself, and weight bearing of the foot is very difficult because you do it every day. So that's something to be worried about. Finding the correct treatment and rehabilitation technique is key for this injury. So bony anatomy for the foot. I circled the tuberosity, or the base of the fifth metatarsal, which is where the fracture happens. There are 5 metatarsals total. The tarsal bones are the calcaneus, talus, navicular, cuboid, lateral, middle, and medial cuneiform. The tibia and fibula also come into play because of the joint above. Then there's phalanges, or toes. So the muscles of the foot, there are a lot of muscles in the foot itself, and I listed those out on the side. The extensor digitorum brevis is in the foot, dorsal interosseous in the foot, extensor digitorum longus kind of goes up towards the ankle, tibialis anterior is in the leg, but the tendon is in the foot, peroneus tertius, flexor hallucis longus, flexor digitorum brevis, adductor hallucis, lumbricals are in the foot, flexor digiti minimi, brevis is in the foot, quadratus plantae, and plantar interosseae. So most of those are muscles in between the toes that connect the tarsals to the phalanges. Some of them go up the leg. And then the soft tissue is just the ligaments. So anterior talofibular ligament, posterior talofibular ligament, calcaneofibular ligament, plantar fascia or aponeurosis, and the peroneus brevis tendon. And the reason that that is highlighted is because that is the sole tendon that connects to the base of the fifth. The plantar fascia also does a little bit. So etiology of the Jones fracture. It happens from a forced inversion and plantar flexion motion, which this can happen from a rolled ankle, or if you come down from a jump or some sort of motion and land straight on the plantar flex inversion position. It'll put pressure right on the bone, the base, and it'll break it. Props to Danny for the foot. So my case study is a 26-year-old male professional basketball player. He was a few games into the season. He landed on an opponent's foot after a rebound. He presented with pain and swelling on the lateral aspect of his foot. He was taken to the locker room for further evaluations where tests were done to see if he had sprained his ankle or if there was a possible fracture. With some of those tests being positive, he was referred to the team physician for the next day for an x-ray. Immediate care for this included ice and immobilized in a walking boot and given crutches so that he didn't waver just in case there was a fracture. So later on, he was given his options and he chose to do the non-surgical approach first, but this failed due to return to play too early, so you refractured the base of his foot. So the surgical approach was then implemented and rehabilitation was followed very closely for this. Treatment options, non-surgical means 6 to 8 weeks in a non-bearing cast. This means no weight at all, so either in a wheelchair or on crutches. And then 6 to 8 weeks of conservative rehabilitation. It's more towards the 8 weeks, so 16 weeks total. Failure of proper rehabilitation is about a 44% rate failure, so 28% non-union, 5% late or delayed union, which can mean that the bone finally healed in the later weeks, like week 15 or 16, and then 11% refracture within the first year. The surgical treatment is screw fixation, and it's done with a 4.5 millimeter screw. It looks huge in this, but that's just the string that they have to help keep the bone in line when they put the screw in. So immediate immobilization is done after the surgery, but the good thing about surgery is that you can start range of motion almost 3 days after you're done with the surgery. And this is shown to have a 98.8% success rate. It says 100% success rate, but I know that it's not true because of all the other studies that have 95 to 100%. So rehabilitation goals are full range of motion of the ankle joint above and the toe joints below, increased flexibility of the lower extremity, both legs, restore strength to 85 to 95% compared to the uninjured foot, and then continually work on balance and proprioception. So for non-surgical rehabilitation, you're at an immobilization and a cast, so you have a scooter or crutches or a wheelchair. So that's 0 to 8 weeks. All you can do is sit and watch your teammates play. And then after you're done, the major focus is on range of motion, and then balance and proprioception. Later, supplement the strength protocol. You want to stay focused on the intrinsic muscle of the foot and the stabilizing muscles of the ankle joint because this often happens from an ankle sprain, so you're working on both the ankle sprain and the fracture. And then flexibility is used every day to help lengthen the muscles worked each day. So surgical rehabilitation, 0 to 4 weeks. So you have the screw fixation and then immediate immobilization in a walking boot. They cannot weight bear, but they can take off the walking boot as soon as 3 days after surgery and start working on just basic range of motion. Flexibility can be used in this phase either on the opposite foot or while they're non-weight bearing. Aquatic workouts can be used for the range of motion and cardiovascular health, especially if their surgical incision is healed. Game ready is used after all rehabilitation to help with the swelling and inflammation. And then weight bearing is introduced towards the later parts of the stage, but still in the walking boot. So 5 to 8 weeks. This takes about half the time of the surgical or the non-surgical rehabilitation to heal. So the walking boot is removed, full weight bearing without walking boot. So normal walking, normal activities of daily life. Hopefully their range of motion is almost completely restored because you can do that right away. Strength becomes the main focus of both the intrinsic muscles and the muscles surrounding the ankle joint. Range of motion exercises are still used to supplement for the first 2 weeks, and then you get into plyometrics, which are introduced towards the later part of the stage. Aquatic workouts are still utilized as recovery and cardiovascular exercise. So some of the functions functional movements that are introduced later in rehab are jogging, sprints, practice warm-ups, which means about maybe 50% of what they would normally do, and then light practice. And these should all be monitored by either the team physician or athletic training staff. So the return to play protocol is kind of a screening process towards the end of their rehabilitation, and it makes sure all the functional movements are restored, there's proper strength testing, and pain-free participation in all of these. So this is the chart that I have laid out. So we have functional movements for basketball itself, so sprints, jump shots, shooting, dribbling, defense, rebounding, vertical jump, and game simulations. The game simulation is super important because that will get them back to full return to play. So scrimmage at 80% with the team, scrimmage at 100% with the team. Play 5 minutes of a quarter, and then play one full quarter, and then play a full half. All of this should be done pain-free and without any sort of noticeable deficit. So the surgical versus non-surgical route, it's pretty obvious that surgical should be chosen for elite athletes because it has about half the rehabilitation and healing time. It is way more successful. It is almost 50% more successful. And surgical has minimal non-union rates. It does happen. Refracture does happen also, but that is because there's an option to take out the screw, and that is when it often happens. Refracture is way more likely to happen with the non-surgical approach because of the weight-bearing aspect, and if that bone is not properly healed or not completely healed, then refracture is definitely something that will happen. Rehabilitation protocol is super important for this and super important to be followed, because if you do not, then we have a case, like the case study, where he returns to play too soon and refractures his foot in the next game. And for surgical rehabilitation, it's important to follow that also, because you want to make sure that the healing of the bone is proper. This is in both cases, but non-surgical rehabilitation is just really difficult because of the lack of blood flow and stuff like that. So if you get the surgical rehabilitation, just screw it, fixate it, then it takes about half the time to heal. References. Yes, these are my pictures. Questions, comments, concerns?
If you get the screw fixation, is it possible to still fracture it with the screw in there? Or is it like?
It would be more of non-union.
What do you mean?
So like, if you don't have the best surgeon, the screw can go in sideways or something, so the bones don't actually heal properly.
Gotcha.
Refracture typically happens after they take the screw out, which some people don't actually do. A lot of people don't take it
So
out.
if you don't take it out, is functionality?
You're back to 100%.
You're good?
You should be back to 100%.
Then why do people take it out?
I have no idea.
Just for funsies?
Comfort. So they don't have a metal screw in their foot.
Did your athlete race or take when he went back to participation?
I don't believe so.
Just had a few questions about the return to play criteria and testing. How was strength tested?
manual muscle tests and also like general calf raises, squats, stuff like that.
In the game simulation, you had 3 steps.
I have 4 steps, I think.
Okay. Was it 5 minutes, a quarter, and a half? What was the?
It was 5 steps. So scrimmage, 80%, scrimmage, 100%, and then 5 minutes, full quarter, full half, and then return to play.
So, with the scrimmage 80%, is that 80% effort or 80% of the scrimmage? Or?
80% effort.
Okay. And the actual game simulations, where you do the quarter, half, and 5 minutes, were those 3 different games?
Yes.
Okay. What was the timeline from surgery to full return to play?
8 weeks.
Initially, you talked about prevalence at 45 to 70% of the fractures in the foot.
Mm-hmm.
Do you know what the prevalence in athletics is?
No, but that was in the paper.
Okay. And I was just curious, do you know, is there any difference in rate or is there any difference in protocol with a stress fracture versus an acute fracture?
I've not looked into it.
That's all I have.
Holy great.
Yeah, I think so.